Are you going to
10.
count me down in the chat?
I'll count you out in as I'm talking.
Oh, okay.
3, 2, 1.
Hello, welcome to Wellness Live. My name is Dr. Olivia Moses, and we're so excited that you've joined us today. A couple of things to know about Wellness Live. If you're watching us live, you can actually type in your comments right into the chat, and we can ask our experienced content expert right here on the spot your very question. So don't forget to do that when we have our Q&A sections. Today is actually we're in February if you're watching us live, and February is National Heart Month. And we, of course, are wearing red for this. Now, you have seen the American Heart Association has done a great job in marketing the color red and wearing hearts during the month of February. Now, why is this such a big campaign for the American Heart Association and medical professionals actually all over the country? And the reason is heart health is one of those things that affects most families. Now, what we are seeing all over the country is individuals having issues with their heart. I do have some statistics here that I wanted to kind of read off to you when it came to heart health. And it continues, cardiovascular disease continues to remain the leading cause of death in this country, with almost 1 million deaths in the year 2020. And what's interesting about that, it also then increases throughout the healthcare system. Not only are our children and our parents and our spouses, all of these individuals that are so important in our lives, really suffering, and sometimes we even lose them to cardiovascular issues, is that it also creates a huge financial burden on the healthcare system, increasing healthcare costs. What we are also seeing is that in 2020, in the United States, coronary heart disease was the leading cause of death attributed to cardiovascular disease. And I wanted to kind of share the breakdown here. Stroke, cardiovascular disease, high blood pressure, heart failure, and disease of the arteries. So all of these things, some of you might have heard of in many, many different venues, whether in your own doctor's visit or through a family friend or relative dealing with one of these issues. So that is why it is an absolute imperative that we have open conversation and really understand the heart and what we can do when it comes to lifestyle. Now, with that being said, I want to kind of share a couple of things. This particular topic is near and dear to me because my father, when I was actually in school, had some heart pain. He actually was visiting me here in Loma, and he had some heart pain, and we were going to a wedding. Now, when we were driving to the wedding, he actually helped us with our luggage, and then when we got to our hotel room, he said, "Take me to the hospital." Now, one of the scariest events in my life. At that time, I had never thought about my father's mortality ever. And we were now sitting in an emergency room with him having heart pain. Long story short, with a lot of trauma in between, my dad had a quintuple bypass. And watching him go through that surgery, watching the recovery process of that surgery was actually quite traumatic for all of us. Sleeping in the hospital, and at the time, I had never seen anybody with so many tubes in and out of him, and let alone being my own father. And so this has been a topic near and dear to my heart. So when it comes to these kinds of issues, it is a very personal thing when we go through these types of events, whether it is a heart attack, whether it is a stroke, whether it is a bypass. I actually had a grandfather that suffered from stroke. So these are all things that affects families very profoundly. And that is why we have a very special speaker here today. His name is Dr. Dennis Grewal. He is actually on faculty here in our Department of Cardiology, and we are thrilled to have him here as our speaker. So as all of us go through, whether it is heart health issues with ourselves or it is health issues with our loved ones, it is important to know that lifestyle can be an extremely powerful intervention for these things. And so, what we want to do, of course, is talk about lifestyle, talk about heart disease, and that is why we have Dr. Grewal here with us today. So, I want to invite Dr. Grewal to kind of take over. If you could share your screen, if you have a PowerPoint presentation that you would like to share. And without further ado, I'd like to introduce you to Dr. Dennis Grewal.
Thank you, Olivia. Sorry for the being late. I was held up in a case. Is my video coming okay?
Yes, you are totally fine. You are ready to go.
All right, so let me share my screen.
And for all of our viewers watching us live, Dr. Grewal literally just came from from a case that he's been in for hours. So if he's a little winded, you'll know why.
I literally just came out. All right. Can you see my slides?
Yes, thank you.
Okay, perfect. So, thank you everyone for joining. My name is Dennis Grewal. I'm one of the cardiology attendings at Loma. And one of the things that I practice here, in addition to general cardiology, is preventative medicine, preventative cardiology, as well as taking care of patients who've had heart attack and strokes. All right, so the title of my talk is Dyslipidemia and How to Manage It. The objectives for today is we're going to learn what exactly cholesterol is and how it functions in our body, how these cholesterol levels impact our health, how we can manage these cholesterol in our body, and once we're started on a therapy, or even if we're not on therapy, if we're trying lifestyle stuff, what numbers are we trying to target and why it's so important? So what cholesterol is, we all need cholesterol to live. It's the principal sterol in humans. There are different types of sterols. You can get sterols from plants, but plants don't give us the cholesterol in our body that we typically think of, okay? So cholesterol comes from two sources. Majority of our cells can produce it, and it's in the food that we eat. And the food is especially from animal-based products. So like meat, seafood, poultry, eggs, and dairy products. This is the predominant source of cholesterol in our diet. Okay, so the role of cholesterol, like I said, it's essential for us to live. It produces essential compounds in our body like estrogen, testosterone, adrenal gland hormones, vitamin D synthesis. It helps us digest foods because cholesterol is turned into bile salts, and that breaks down the food that we eat. And all of our cells are have a structure or barrier to it, and that is made up of cholesterol products. So how does cholesterol move around in our body? Well, they're packaged in little special circles called lipoproteins, okay? Then these are sphere-like structures. So these bus our cholesterol to many of our organs for essential function. Like I said, they're the building blocks for our cells. They produce our hormones. We use them for energy, and they fight infections. So how can excess cholesterol be harmful to us? Well, excess cholesterol can be deposited in areas where we don't want them to be. So what does this happen? What is the result of excess cholesterol? Well, it can lead to heart attacks, strokes, and reduced circulation in our legs, causing ischemia or lack of oxygen and blood flow. So how do we decrease the risk of cardiovascular disease? Well, we need to talk about the causal and modifiable risk factors. So these are things like inactivity, so lack of exercise, diet, cigarette smoking, diabetes, high blood pressure, and the focus of my talk, which is cholesterol or ApoB containing lipoproteins. And I'll explain what this means exactly in a little bit. So one common question I get a lot is, doc, how much should I exercise? Well, our guidelines and our steering committees recommend at least 150 minutes of moderate intensity exercise per week. So I get a lot of questions as to what moderate intensity means. Well, if we look at this chart, moderate exercise is a brisk walk, a bike ride, ballroom dancing, active yoga, or swimming. So this is what we call moderate intensity. Vigorous would be instead of a brisk walk, now you're running or jogging, you're biking at greater than 10 miles per hour. You're playing sports, tennis, basketball, or swimming laps. So back to our talk about cholesterol. So how are we diagnosing high cholesterol? Well, when we get a cholesterol panel, this is what our doctors and our patients are looking at. We're looking at our total cholesterol levels, our HDL levels, our triglycerides, our LDL cholesterol. When we check LDL cholesterol, this is the weight of the cholesterol in these cholesterol products, in those spheres I was talking about. Another thing I get a lot of questions on is, hey doc, I want you to check my apolipoprotein B. And I'm going to talk more about that because we're hearing more of this term in social media and the news, and my patients have a lot of questions regarding that. So when we check cholesterol levels in the body, we're essentially checking for many of these, okay? And the LDL that we get in our cholesterol panel is based off an equation, and we get that number, okay? And every one of these cholesterol products are considered atherogenic. What that means is they have the potential to go into the artery wall and invade that wall and cause plaque and inflammation, which ultimately can lead to heart attacks, strokes, or the reduced circulation in our legs. So if you can notice, all these particles have one ApoB molecule. So this is felt to be a much better representative of how excess cholesterol can be harmful in our body. So when we see patients in clinic, let's take the population that's never had a heart attack or stroke, okay? So how do we know who needs treatment for their cholesterol levels? Well, back in the day, we did very long studies where we followed patients and we saw what happened to them, okay? So, and then we come up with a formula, and that spits out a percentage that lets us know what the risk is to our patients. So we use their race, their gender, their age, their cholesterol levels, if they're on any blood pressure medications, if they're diabetic, or if they're actively smoking. So let's say you put in all these numbers and you get a 10% risk. So what that means is you have a 10% chance of having a heart attack, stroke in 10 years. Okay, so that would be you would fall in the intermediate risk category. This is when we would really start discussing cholesterol lowering therapies. Some patients are very high risk and they're at 20% risk over a 10-year mark. And those are patients we really have to talk about starting lipid lowering therapy, which I'm going to talk about next. Okay. Another entity that I want people to be familiar with is familial hypercholesteremia. This is actually very common in the population, as common as 1 to 250 to 1 to 300 people walking around with this disease. So this is a genetic disease. You're born with it, and it causes very elevated cholesterol levels, okay? And so when do we suspect this disease? So the cholesterol panel I was talking about, if the cholesterol is greater than 190, the LDL, there is heart disease in the family and it's premature. For example, if your if your dad had a heart attack at the age of 40 or 50, that would be very alarming, okay? And like I said, this disease is a result of mutation in certain genes. And this is some of the physical features that we can see on exam. We'll have enlarged tendons and areas where our bones are, and we'll have cholesterol deposits around the eye. So that brings us to the next part about if we have elevated cholesterol and we're in a risk category, what can we do to help our patients? So how cholesterol lowering drugs work is the statins that we commonly think about is it inhibits this enzyme here. So we make less cholesterol, and then our cells in our body grab more cholesterol from the blood. So if this is our blood vessel here, this LDL cholesterol molecule is being grabbed by this receptor. We have newer drugs that I'll talk about because some patients cannot tolerate statins for side effects, okay? And I have a question here. Olivia, you want me to take this question now or at the end? One of the questions in the comments is, how do vegans get high cholesterol? So I'll go back to my point about cholesterol. So majority of the cholesterol is made in our body, about 70 to 80%. We don't get too much from our diet unless you're on special diets that are very, very, very high in saturated fat, like a ketogenic diet, things like that. So much of the cholesterol is made in our cells. So that could be a reason why vegans or vegetarians who don't eat a lot of animal-based products can have high cholesterol. Okay, so a lot of the statins that we start in the cardiology field can be any of these groups. Okay, so the medications that lower the LDL the most and what patients are commonly prescribed when they see a cardiologist because they've had a heart attack or stroke is atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. And this can decrease the LDL by as much as 50% or more. Okay. We have other drugs. So some patients cannot tolerate statins due to side effects. So I see a lot of those patients in clinic and they feel like they're unable to lower their cholesterol. They try lifestyle, dietary changes, but like I said, the body makes a lot of cholesterol on its own. So some patients get disheartened because they can't tolerate statins due to side effects like muscle aches. So they feel like they're at a loss. There are no other options. But now we have many, many medications we can prescribe them. Ezetimibe is one of the a common medication. It's a generic, so it's cheap and it's been around for a while, and we have outcome data on it, which is really good. And how this medication works is when we eat animal-based products or food and we have cholesterol, one of the ways it's absorbed in our intestines is through this protein, and ezetimibe can block that. Therefore, we can discard the cholesterol, excrete our cholesterol that way. Another medication class that we have are the PCSK9 inhibitors. I have a number of patients on this medication. So the reason to start this medication is we can't get their cholesterol down on just the statin, or maybe they have side effects to statins, and the ezetimibe is just not lowering it enough. So we have these medications which are injectable medications. They can be taken every 2 weeks, every month, or we have a formulary on our hospital where it's one injection every 6 months. And this injection is just in the fat, like you would give yourself insulin. It's not in the IV or anything like that. It can be, some of these medications can be given at home. It's very easy to give. And these are incredibly effective medications. They'll lower your cholesterol by as much as 60 to 70%. All right. So when I talked about seeing patients in clinic for primary prevention, these are patients who've not had a heart attack or stroke. So where does the data come to treat these patients? So for example, if I have a 55-year-old man, otherwise healthy, but he has type 2 diabetes, and his cholesterol levels, his LDLs in 130s, 140s, there is very good evidence to try to lower his LDL or ApoB. And this is one of the trials that we did. And this took patients that had cholesterol levels about 120 to 130, and they had a high CRP, and they gave them the statin versus placebo, and they followed them for a number of years. So in 5 years, there was less heart attacks and strokes in the statin group versus the placebo. And you would need to treat 25 patients over the course of 5 years to reduce one event. And in the cardiology realm or in the medical field, that is very strong evidence for the use of statins. Secondary prevention has more evidence because these are sicker patients. These are patients that have had a heart attack, a stroke, or a blocked artery in the leg, and they need their cholesterol to be as low as possible to prevent future events. Okay, so the data for treating those patients comes from a study done many years ago, and it's called the Scandinavian Simvastatin Survival Study. This took patients who had a prior heart attack or were having chest pain. They gave them a statin versus placebo, and they followed them for a total of 5 years. And you can see in this curve that this is the patients percent of patients alive, So at 6 years, a lot more patients were alive in the simvastatin group, okay? So this is the early studies that we've done that showed that statins do help patients. But it's not only about statins. We have to take the whole picture into consideration. It always starts with lifestyle, diet, and these are other modifiable risks that we can help patients with. So many of the commonly asked questions I get about cholesterol lowering therapy is, a lot of patients can have report side effects to statins. Well, what I tell patients is the muscle soreness, the muscle aches they get for statins, when we were researching this in the trials, many of the patients in the placebo arm had the similar symptoms. So usually I will have patients, what I give tips for my patient is I want them to document their symptoms. Because a lot of time they'll have a hard day at work or they go to the gym and the soreness they feel, they blame it on the statin therapy, which, is not from the medication. And we have various strategies to deal with this. We can decrease the dose of the statin. We can take them once or twice a week and then increase the frequency, or we don't have to do the statins. We can try many of the other lipid-lowering therapies that we have. I get a lot of questions about statins being linked to dementia. We've had a number of studies looking at this, and there's no correlation between statins and dementia. If anything, statins reduce the risk of stroke. And if you've had strokes or multiple strokes, that leads to dementia. So by reducing the risk of strokes, we're also decreasing the rates of dementia. I get a lot of questions about, is it absolutely imperative that I need to take statins? Well, going back to that risk calculator, this is a good way for us to calculate risk for our patients for heart attack, stroke, or blocked arteries in the leg. And based off that, that's how we educate patients if they need lipid-lowering therapy, if their lifestyle and their dietary interventions don't help with reducing their cholesterol levels. And once on medication for cholesterol, I get asked a lot, like, how often do I need to follow up or repeat this lipid panel? You can do it as early as 3 months. All these lipid-lowering therapies work pretty quickly. So, I like to check it in the first 3 to 6 months, because if the medication that I'm giving or the intervention we're trying doesn't work by then, we have to figure something else out. Okay.
Dr. Grewal, is this
Yeah.
a good time to have our midpoint Q&A?
Yeah, absolutely.
Okay, so we have some questions coming in. So the first question is, my doctor said I need medication, but I would like to do this naturally.
Yeah.
How is this possible and advised?
So I always, when I see patients in clinic, we always start with lifestyle interventions first. So, but that depends on the risk. If someone is incredibly high risk and has had a heart attack or stroke, we're going to need assistance, most likely with medications to help bring that cholesterol. But let's say someone walks in, with some risk factors, they haven't had a heart attack or stroke, we can try with diet, okay? The diet that I usually recommend to patients, and personally I follow, and that has a lot of data backing it, is a Mediterranean diet. So this is a diet that's not high in saturated fat, advocates healthy fats, extra virgin olive oil, avocados, nuts, things like that, whole grain products. So that, and coupled with exercise, I think, patients can do very well on, especially when they're on the extremes of one edge. So if someone has obesity, diabetes, by exercising and getting their weight down, we can get a lot of these cholesterol levels decreased.
Another question we have are there any natural supplements that could help me with my cholesterol?
So, the natural supplements, I get a lot of question about like red yeast rice, turmeric. We've studied those. Some patients can have cholesterol lowering from this, but it's not to the extent it's going to put a large dent in the cholesterol numbers. I think if you're doing everything right, diet and exercise, and the cholesterol is not coming down, we have to see what else might be going on. They could have, like I said, this genetic disease, familial hypercholesterolemia, that is actually pretty common and is very underdiagnosed.
So in my family, here's another question. In my family, it's mostly men who have a heart condition. I, as a woman, what are my risks?
So I think that's a great question. I think we don't do a good job of diagnosing heart disease in women early enough, and that's been shown, and that's why you know um, whether men versus women are a higher risk. I think I like to look at the individual, but I also need to have to mention that heart disease is underdiagnosed in women quite frequently because they'll present with symptoms that what we call are atypical, meaning they don't follow textbook symptoms for certain disease processes. But just because, let's say, if I saw a man or woman with similar cholesterol levels, let's say they're very, very high, I would treat them the same.
Okay, great. Well, shall we get back to your presentation?
Yeah, I think I only have one more slide.
Okay.
All right. So once we start talking about lipid-lowering therapy and the interventions, we want to see if we're hitting certain targets, okay? So patients that have had heart attack or strokes, we want to get their cholesterol as low as possible. So we try to shoot for an LDL, less than 70 would be great. Ideally, it would be less than 55. Patients with the genetic condition that I talked about, like familial hypercholesterolemia, and let's say they're young and healthy, but they have very high cholesterol levels, we want to get that cholesterol as low as possible because they do have a genetic basis for this elevated cholesterol. Patients that are high risk for heart attack or stroke, based off the calculator that I mentioned, if they're in that 20% risk category or greater, we want to get that LDL less than 70. Patients at low risk, we would like to see that LDL less than 116, 115. Okay, and that sums up my presentation. If anyone has more questions, I'd be happy to answer them.
Sure, Dr. Grewal, we have other questions coming through. This actually, it's interesting that you and I are getting this. So, I'm South Asian, and it
Yeah.
seems like many people have heart conditions in my family. Is this just my family, or is there something about our population?
Yeah. I think when we studied heart disease in the US with these studies, a lot of them excluded South Asian background. So we have special calculators that when we followed, South Asian populations, we have specific calculators like the MESA calculator that takes that ethnic population into consideration. But, I do agree, South Asians are a very high risk. There's many comorbidities that we have, high blood pressure, diabetes, and so these are important groups that we cannot miss. So when we see patients in clinic, I think not only do we have to look at each patient, we look at all patients collectively, but we should take the individual risk profile into consideration too.
Okay. Another question is, can my heart disease be reversed?
Yeah. So if patients have so this is a little bit nuanced question. So let's say, if you have risk factors, diabetes, high blood pressure, elevated cholesterol, all those risk factors can be controlled and potentially can be reversed. I have patients that lose a significant amount of weight. We roll back their diabetes medications, they come off high blood pressure medications. So, lifestyle and dietary changes are at the cornerstone of what we treat and preach.
Okay. And then another question here coming through regarding lifestyle. Is
Mhm.
there some specific food that I can eat that potentially help basically their heart?
Yeah, like I alluded to before, I think one of the diets I try to recommend is a diet like low in saturated fat. And I have patients that they don't want to give up their animal-based products, and I understand. So in moderation, I like a Mediterranean diet that is it's not too restrictive. It works across many different ethnicities, and it could be applied broadly. And like I said, it's not restrictive at all. You have a lot of food options in that diet.
And one of the questions I like asking for
Yeah.
everyone is basically when is it a good when should a patient decide to see a cardiologist if they're getting followed up with their primary care physician? Who
Yeah.
actually needs to go to see a cardiologist specifically?
I think many of the interventions we do in terms of primary prevention and even secondary prevention can be done by the primary care doctor. But I would have a discussion with your primary care physician to see, is there anything else that needs to be done? I think it's always good to get a second opinion or someone else, a fresh eyes to look at a patient, so to speak. So I would say patients in high risk categories who have a strong family history of heart disease, who could have a genetic, definitely patients that have familial hypercholesterolemia should be followed by a cardiologist, because it is, underdiagnosed. And that's, we know about that. And then anyone who's had a heart attack, stroke, or the blocked arteries in the leg. Because if you have blocked arteries in the legs, chances are you could have blocked arteries in the heart, or in the vessels to our brain. So, we need to try to catch these patients before they have a clinical event like that and try our best to prevent those.
Okay. Well, if there was one take-home message that you could give our audience today, what would you want them to leave with?
Um, I would say, many of my patients, they do a ton of their own homework, which I always like to see. So keep researching on what can make you healthy. Diet, I want patients to get out there, be more active, make those lifestyle changes, which, will help them in the future. And don't be afraid or speak up or ask your primary care physician, family care doctor if you would like to see a referral to a cardiologist to address whatever needs that you might have, to see how we can help. But I think overall, I really preach lifestyle changes. So if there's one take home message from this lecture, I think getting out there, being more active, being healthier, changing the way you live in terms of diet, exercise is the way to go.
Okay, well, thank you, Dr. Grewal, for joining us today. And I want to thank all of you for joining us as well. You don't want to miss our next session that will be talking about relational health and how to have conversations during conflict. So again, thank you so much for celebrating National Heart Month with us here at Wellness Live. My name is Dr. Olivia Moses, and we'll see you next time.
Thank you, Olivia.